Welcome to Falcon Review of Pathology for USMLE Step 1. We are continuing our lecture on bone pathology. In this section, we will be dealing with cartilage-forming tumors, fibrous tumors, and other tumors that develop in bone, along with metastatic disease and epiphyseal lesions, a unique group of lesions that contain only a couple of entities and that are worth knowing about, as they allow you to simply look for the word epiphysis in the STEM new question and then essentially start looking for the right answer in terms of what tumor is present without knowing very much else about the patient or clinical presentation of the tumor entity. But to begin with cartilage-forming tumors, the first tumor that we need to consider is the chondroma, a benign tumor of cartilage that is a predilection for patients between the age 20 to 40. Generally, these tumors will be solitary, and they like to be located in the metaphyseal tubular bones of the hands and feet. Radiologists will describe what they call the ring sign, which is an ovolucency surrounded by a rim of dense bone. The predominant malignant tumor of cartilage is the chondrosarcoma. As the name implies, this is a tumor that simply arises from malignant cells that produce cartilage. It may arise from pre-existing chondromas. Unlike chondromas, however, it has a predilection for older individuals, generally occurring in people over the age of 40, and it has a predilection, like many of the bone-forming tumors do, for the male sex. Clinically, this tumor likes to appear in the central skeleton, so think about it in areas such as the pelvis, the shoulder, and ribs, versus the chondroma, which, as we indicated just a moment ago, has a predilection for the distal extremities. Chondrosarcoma presents as a painful, slowly enlarging mass within the central skeleton. Now we'll move on to fibrous tumors. One will want to always keep in mind the possibility of fibrous dysplasia when thinking about a fibrous tumor. This is a benign tumor-like lesion which is characterized by the replacement of bone by fibrous tissue. Think about this tumor when one is looking at some sort of fibrous lesion that's occurring within younger individuals, particularly adolescents. It can present either as a single lesion or as in multiple sites. If you have a young lady who's presenting with multiple lesions along with café au lait spots and endocrine abnormalities, think about whether she may be suffering from a particular syndrome known as McCune-Albright syndrome. These patients tend to present with their lesions presenting unilaterally, both in terms of bone and skin. That is, the café au lait spots on their bony lesions will present predominantly on one side of the body versus presenting bilaterally. Due to their endocrinopathy, these young ladies will also present with precocious puberty. They will demonstrate hyperthyroidism, the presence of pituitary adenomas, and primary adrenal hyperplasia. Fibrous dysplasia, when examined on X-ray, gives a ground glass appearance to the areas where the bone has been replaced by this woven tissue. Some authors use the term alphabet soup to describe the trabeculae of bone that you see here in this fibrous background, in this picture of fibrous dysplasia. The term alphabet soup refers to the poorly formed trabeculae of bone that take on a variety of shapes in this background of the fibrous matrix. Other tumors that you want to think about when you're dealing with bony tumors include a small round blue cell tumor, known as the primitive neuroectodermal tumor, or when it's in bone, more often referred to as Ewing sarcoma. Ewing sarcoma, like synovial sarcoma, presents with a particular translocation, and often one needs to identify this translocation to assure oneself that one is actually clinically dealing with Ewing sarcoma. The translocation is between chromosomes 11 and 22, with the change being in where the location of the Ewing sarcoma gene. In terms of the clinical features of this tumor, it generally presents in younger individuals, those under the age 20. It has a predilection for appearing in the diaphysis of long bones and will appear clinically as a painful, enlarging mass. Also think about this tumor possibly within the flat bones of the pelvis. The early stages of this tumor can mimic osteomyelitis, acute osteomyelitis, and make for a clinical conundrum both for clinicians and patients. The pathology will be seen, Ewing sarcoma will be seen as a soft tissue mass that invades through the cortex and periosteum. When looked at under the microscope, it has a small round blue cell appearance, similar to what one might see, for example, if dealing with a neuroblastoma elsewhere in the body, or if one were looking at a medulloblastoma within the posterior fossa of the brain. One can often confuse these tumors with lymphoma, and sometimes a workup with appropriate immunohistochemical markers or flow cytometry is necessary, along with looking at cytogenetics to determine if the translocation between chromosomes 11, and 22 is present. One particular histologic feature that you may hear the pathologist referring to is the presence of Homer-Wright rosettes. These are rosettes of these small round blue cells arranged around a central space. This indicates the presence of neural differentiation within these tumors. We have stressed in our lecture here on bone and cartilage tumors that often if one knows the location where a particular lesion is, that will allow you to significantly narrow the differential of what the possible lesions could be. This diagram is worth memorizing before one goes into USMLE Step 1, as it breaks down a long bone into three regions: the epiphysis, the metaphysis, and the diaphysis, and lists the lesions that you are likely to find in each place. Hence note that within the diaphysis, one can see lesions such as osteoid osteoma, round cell lesions such as Ewing sarcoma or histiocytic lymphoma, adamantinomas, fibrosarcomas, and fibrous dysplasia. Note that there are a relative paucity of lesions within the epiphysis, predominantly the chondroblastoma and the giant cell tumor. Hence, if you are reading a question and the stem indicates that there is a lesion within the epiphysis, look amongst the answers for either giant cell tumor or chondroblastoma, and potentially you can save yourself some time on this question on the exam. The giant cell tumor, as the name implies, is a tumor of multinucleated osteoclast-type giant cells. It has a predilection for patients between the ages 20 to 40 and likes to arise near the knee. On X-ray, this can appear as a lytic lesion and make one worry potentially about some sort of metastatic lesion with osteolytic effects. It can be locally aggressive. In addition, when this lesion is curetted, often these cells can be spilled into the surrounding bloodstream and make their way to other organs. Hence, a patient who has a giant cell tumor of the bone may present later on, after having the initial tumor resected, with giant cell tumor, for example, of the lung, where it has spread hematogenously, not so much due to any metastatic potential of the tumor itself, but just due to the fact that the tumor was exposed to local blood supply while it was being curetted. The other tumor to think about in dealing with the epiphysis is the chondroblastoma. This is a rare benign tumor, not surprisingly of chondroblast given the name. It has a predilection for males in their teen years, and most of these are going to occur near the knee. Radiographically, these will appear as well-defined lucencies with spotty areas of calcification throughout the tumor. What one sees histologically is a series of tumor spells interspersed with nodules of hyaline cartilage. For those of you who go into hematology or oncology, the great majority of bone tumors that you're likely to deal with are most likely to be metastatic disease. Metastatic disease is the most common form of skeletal malignancy and leaves one thinking about a small set of primary tumors that are likely to go to bone. There are a variety of mnemonics for trying to remember which tumors are likely to go to bone. One of the more favorites that you may read about in the various USMLE review materials is the sentence, P.T. Barnum loves kids. P stands for prostate, T stands for thyroid, Barnum stands for breast, the love stands for lung, and kid stands for kidney. Those are the tumors which are likely to metastasize to bone. The locations that can be involved can vary, but the vertebral column, the pelvis, ribs, the skull, and sternum all happen to be common areas for primary lesions to metastasize to. That ends this lecture in the Falcon Pathology Review Series for USMLE Step 1 on bone pathology.